Well, good morning, everybody. It's been a beautiful weekend, right? Hard to come in and listen to my talk after this beautiful weekend, wasn't it, right? At least we don't have a snow on the ground. That's great, right? We shoveled enough snow this year. So let's take it off. I'm sorry my voice is a little bit off because I have a cold, but hopefully I can get through it. We're going to talk about aortitis. Not only serious and rare, but also there are a lot of questions about it. Not a whole lot is known about aortitis. Sometimes we scratch our heads many times to try to make a diagnosis for aortitis. And even I went for the International Large Vasculitis Symposium for at Mayo Clinic just a month ago. I thought I'm going to know more about it. I get more confused because still a lot of questions about aortitis. So I'm going to summarize a few things about aortitis. Hopefully I can get some questions at the end. There's some disclosures that have nothing to do with my talk today. So what we're going to try to learn today, we're going to discuss different pathogenesis and etiologies for aortitis. And then I'm going to share some few cases that, actually most of the cases I'm going to share are actually our own cases, but there are about 3 cases that I got from colleagues around the country here. We're going to focus on the challenges making the right diagnosis, as I mentioned. We're going to discuss our published case study. And we're going to talk about our own recommendations for the workup and management of aortitis. I'm going to end up with a summary. So what is aortitis? It's a very rare disease, as I mentioned, with different underlying pathogenesis. It could be inflammatory, infectious, malignant, and idiopathic. Sometimes you do a lot of workup and you can't find a diagnosis, and we call it idiopathic aortitis. And as I said, taking diagnosis and working through a differential diagnosis is very, very challenging. And you're going to see when I go over the cases, most of the cases will come with abdominal pain or chest pain, elevated inflammatory markers. And then you look at the CT, oh my goodness, they're all kind of similar or same. And then we're going to talk about some management as well. And the management is based on underlying etiology. And it has to really have a team that's really put a time to learn about aortitis, because as I said, there are a lot of unknowns about aortitis. As I said, sometimes we scratch our heads. Oh, this is inflammatory. No, this is infectious aortitis, right, Dr. Titus? Think a lot about what's the underlying cause. Is it genital aortitis? Is it Takayasu? What is it going on? By the way, I put the monkeys there because actually monkeys do get aortitis. All right, so inflammatory aortitis, what kind of etiologies that we see with inflammatory aortitis? The prototypes that I'm going to go over is genital aortitis, Takayasu aortitis, IgG4, which has started to gain a lot of really interest that's out there, and periaortitis, and we're going to go over each one of those. But also it can be secondary to lots of other diseases. Any type of vasculitis can actually lead to involvement of the aorta, including even small vessel vasculitis. I'm going to go over a case that actually presented to our center with C-ANCA vasculitis and had significant involvement of the aorta. Connective tissue disorders, and also rare diseases like, Erdheim-Chester Disease, which is a histiocytosis involving the aortic wall, and also radiation. But as I said, sometimes you do all the workup and we don't know what's causing the aortitis. We call that idiopathic inflammatory aortitis. Infectious aortitis, very serious disease, can be caused by multiple bacteria and viral and fungi as well. We've seen a few cases, and I'm going to share one of these cases with you as we move forward. Malignancy could be a primary malignancy of the aortic wall, but also I've seen cases with leukemia and lymphoma. Actually had a lady that came down with lymphoma, and she was treated with radiation and she was treated with chemotherapy and found significant involvement in the thoracic aorta. So let's go over the cases now, right? So this is our own case. A 52-year-old female, 5 years history of shoulders and hips pain. She presented with kind of a mid-abdominal pain and also fever, chills, and night sweats. Vital signs are normal, but she has a para-umbilical abdominal tenderness. And like all other cases that I'm going to list, just a warning, they're going to all have elevated ESR and CRP, right? And here, risk of workup for autoimmune diseases as well as blood cultures to rule out infectious disease etiologies were unremarkable. This is her CT angiogram of abdomen pelvis. This is an axial view. This is the inferior abdominal aorta. You see there is a significant wall thickening of the aorta here. You don't see really atherosclerotic plaque, and I think, but there's about, I would say here, about 8 to 9 millimeter of wall thickening around the aorta. And this is more of workup that we've done, and actually we made the diagnosis for giant cell arteritis for her. I'm going to say why as we move forward, but I can tell you that she's a female older than 50 years of age. She had inflammatory markers elevation, and she has a vascular involvement as well. And she was treated with prednisone, 40 milligram once a day for 4 weeks, and we started to slow taper her prednisone. And she had significant improvement of her symptoms in 3 weeks. Inflammatory markers improved actually in 4 weeks. And I followed her for 1 to 3 to 6 months, and this is her CT angiogram actually 6 months later, and you see a significant improvement of the aortic wall thickness here, as you see. And what is giant cell arteritis? As you know, it's a grammatis large vessel, usually it's large vessel vasculitis. And there are 2 types. We used to call cranial type a temporal arteritis. There is more kind of now changed the name to large vessel as well as cranial vessel giant cell arteritis. And the diagnosis, patient has to have 3 of the following here. So our patient was 50 years older than 50 years of age. She had actually unexplained fever, anemia, fever and constitutional symptoms, and she had elevated ESR and CRP. And she had a long history. Remember, she had shoulders pain and hips pain for about 5 years, and that's why we thought about giant cell arteritis in her case. So, as I mentioned, there are 2 types of giant cell arteritis: large arteries involvement and cranial giant cell arteritis. Usually for larger cell involvement, patients are usually younger, like our patients. It's not like she's not 75 like the regular patient they see with GCA. And usually the diagnosis is made years later, like our patients. Remember, she had PMR symptoms for the past 5 years prior to coming to us. And it's lower frequency, actually, is to have cranial involvement or visual manifestation. Our patient did not have neither one of those. And guess what? Temporal artery biopsy is positive in less than 50%. A lot of patients think, oh, so Dr. So-and-so referred me to you to have a temporal artery biopsy. Well, the yield for temporal artery biopsy, especially for the large type, is not that high. It's less than 50%. And also, these patients are less likely to meet the American College of Rheumatology criteria. They're 9% only versus 95%. So one of the most kind of challenging part of actually working with patients with aortitis or rheumatological disease affecting the vessels is to try to determine the activity of the disease. So are you going to base your determination based on the symptoms and or the inflammatory markers and the imaging findings? Actually, it's all together, but we are waiting for standardization to kind of find out what is the best way to kind of characterize the activity of the disease. Okay, so elevated ESR and CRP. Most of the patients can have elevated ESR and CRP. As a matter of fact, elevation of ESR and CRP not always really can confirm active disease. Vice versa, if the patient has normal ESR and CRP, about 10% of these patients had active disease. How about PET scan? We've kind of used PET scan here and there, but I got to tell you that it has a good sensitivity to show really if you see high uptake in the PET scan, there's something going on. There's an activity. There are inflammatory cells or infectious cells that's actually occupying that space. But unfortunately, specificity is very low. Post-op, you see actually, false positive in post-op patient, and even after endo grafts, you see active uptake there. And also, atherosclerosis can also give you high uptake. But usually with infectious or inflammatory aortitis, you see significant SUV elevation. And they are actually now, currently, they are working on a new ligand that actually will be very specific for inflammatory cell involvement. So what is the management for GCA? As I mentioned, we usually start prednisone. It's being like the conventional way of treating, giant cell arteritis is being actually to give high-dose prednisone, usually continue for 2 to 4 weeks. My practice has been giving those for 4 weeks and bring them back in a month. And we usually start tapering down in a month, but you go slow. I'm not going to go into details. Do we have a steroid-sparing agent? It's unfortunately that when you give these patients steroids, you feel sorry for them. because they come with a lot of complications. They come with the moon face, buffalo hump, all this Cushingoid kind of features that you don't want to really see in your patients. So currently, the only drug that's currently FDA approved to treat patients with giant cell arteritis based on a controlled randomized trial is interleukin-6 inhibitor, which is tocilizumab, or Actimra, in other words. That actually has been there to treat patients with rheumatoid arthritis and other rheumatological disorders. Based on the study that we were able to show that there is a decreased rate of first relapse with tocilizumab and significant reduction of steroids over time. So I think this is really a great kind of a tool or a drug that we can use to reduce the dosage of prednisone over time and to get patients into remission sooner. There are a lot of kind of confusion now about should we start tocilizumab right away in patients with giant cell arteritis, or maybe give them steroids for a month and see what happens if they don't respond and you actually consider it. The good news is it's a sub-Q once a week for a year that we usually use. But again, a lot of questions about the dosage, but at least we have a good drug that would spare the high dose of steroids and get patients into remission. And we've used methotrexate for long, but if you look at, there is a meta-analysis that recently published that the data behind using or to support using methotrexate and GCAs is not that great. At best, it's moderate, so probably not because it has a lot of side effects. There's also promising data for abatacept, which is a CD4 inhibitor, ustekinumab, which is actually interleukin-12 and 24 inhibitors. These two cells here, the TH1 and TH17, play a great role in the pathogenesis of GCAs. And DMARDs as well can be used. When I first started here, we used some TNF inhibitors in these patients. Currently, we know that there is no really good data to support the use of TNF inhibitors in patients with GCAs. All right, so do we have data on operating on patients with GCAs? I think that's kind of, probably relevant to my colleague vascular surgeons here. We do actually have limited data, but the bottom line before I show the slide is actually you try to take patients to the OR when they don't have active disease. If you don't take these patients when they have active disease, you set yourself up with complications because the vessel wall could be very fragile and you don't operate on these patients. Based on a paper that was published by Gaini and his colleagues in the European Journal of Cardiothoracic Surgeon, looked at 40 patients that required surgery. All of these patients had descending aortic involvement. 4 patients had to actually go for emergent repair. 13 of these patients had elevated ESR and CRP that were coded as active disease. Actually, these patients did really well. These are the post-op kind of complication. But if you look at the freedom for intervention during the study's follow-up, which is about 9 years, the only 4 patients had to be re-intervened on. And actually, we noticed, I was reading that paper, we noticed that patients with active disease had disease progression than patients who did not have active disease. And the 5-year survival is about 91%. So what is the prognosis and relapse for patients with GCA? Relapse actually reported, and it's a wide range because, patients with large vessel involvement like the aorta have actually higher relapse, especially these patients can come back years later with aneurysms, especially inflammatory aneurysms. And the 5-year survival is actually not that bad, actually, in these patients. And 50% of these patients were able to get off prednisone after 5 years. And as I said, aneurysms have really associated with higher mortality, and you can see these patients even years later with inflammatory aneurysms. So this is GCA, we talked about it. Let's go over a second case. As I said, most of the cases are going to present similar, right? So this is a 48-year-old young lady that presented with significant left lower extremity pain and purple discoloration. She also had 1-month history of feeling malaise and sick. She also had buttock pain when she walks. So this is kind of claudication that she presented with as well. Vital signs, she has tachycardia, and the foot is actually, you can tell that there's some ischemic problem that's going on the left foot. There was no palpable pulses in the pedal arteries. And this is her lab work. ESR and CRP as I promised. Most of these cases will have elevated ESR and CRP. She has some hypercholesterolemia. The rest of the workup, including cultures, came back negative. And her ABI actually moderately reduced bilaterally. with monophasic waveform throughout that tells you that there's an inflow disease. So let's see what is it that's causing the inflow disease. There you go. So this is a CT angiogram, axial view of the abdomen pelvis, and you see the infrarenal abdominal aorta is very, very thickened. And you see the aortic actual lumen is almost really occluded. And if you go down at the bifurcation to the iliacs, you see significant involvement of the bilateral common iliac arteries as well, as you see here. And this is the coronal view. You see how much the aortic wall thicken, and you see almost subtotal occlusion of the bilateral iliac arteries. So what the heck is going on in this young female, right? And there's a significant wall thickening right there, and she's young and she's female. How about a Takayasu Arteritis? By the way, we did a CT angiogram of neck and chest, and we did not see any involvement of her major vessels of the arch. And I'll tell you why we thought about type 4 Takayasu Arteritis in a second, but from now, she's younger, she's female, she has significant stenotic lesion in one of her major vessels. So she was started on prednisone and aspirin and statins, and we sent her for walking program, and we thought we were done. Yet, she comes back 3 weeks later with sudden onset left leg pain. That's much worse now. And actually, she was cold and purple. And we diagnosed her, of course, with CLI. So what the heck is going on? I thought we started her on steroids. She should feel better. After starting her on IV heparin, this is her seat. Actually, you see that the wall thickening is slightly better, but look at the left common iliac artery is completely thrombosed. And so this is the coronal view. You see that actually the inflammation is slightly better. She still has quite a few inflammation down there of wall thickening, I would say. And there's, the wall thickening has improved, but here you see really total occlusion or thrombosed left common and external iliac artery. So the patient was taken for catheter-directed lytic therapy. She had thrombectomy. And actually, I intentionally put this kind of complications. She actually had right iliac artery dissection. Why I put it there? Because as I told you, you do not need to operate or touch these patients if they have active disease. But this patient, we had to because she had significant, she came with CLI, and we had to intervene on this patient. And just to let you know that she had that complication because the right common iliac artery was significantly inflamed. The good news, she continued to do well on aspirin and warfarin and atorvastatin. And 2 months later, her symptoms actually got better and normalized. ESR and CRP and ABRs were normal. This is her CT angiogram 2 months later. You see actually improvement, you continue to see improvement in her aortic wall thickening as you see on the slide. This is at the bifurcation, and this is the coronal view. You see actually significant improvement in her inflammation, yet she still has way to go. Takayasu Arteritis. Okay, so it's a very rare disease, especially in the United States here, as I'm going to mention here in a few lines here. And it's usually affecting the aorta and large branches of the aorta. And manifestation, usually we see these patients, they present when they're younger than 40. And it's most commonly in females, as I mentioned. And it's very prevalent in Japan, although here we see 1 to 3 cases in a million in the United States. As a matter of fact, in my practice, we have about 12 patients with Takayasu Arteritis. Clinical presentation, there are early symptoms, constitutional symptoms, but also later down the road, they can come down with significant arterial stenosis-related symptoms like ischemia and hypertension, and sometimes they come down with aneurysms and dissections that you have to intervene in these patients. So what do we know about Takayasu in patients who are 40 years or older? As I said, usually they present younger, but those patients that present older than 40 years of age, based on the series from Japan, actually 43% of Takayasu patients present at age of 40 or older. And what is what is different for these patients that present at 40 years or older than 40 years of age? Actually, they have less carotid involvement, but more coronary involvement. Actually, we took care of a patient that presented with coronary Takayasu here. I'm not sure who was the cardiologist. And then they have more dyslipidemia and hypertension. Diagnosis, of course, it's clinical diagnosis plus the imaging. We look at the images and see, if there are significant stenotic lesions, and plus the inflammatory markers in the age and the gender. And then PET scan can be helpful, but as I said, it can be falsely positive on many other things. Based on the angiographic involvement or anatomic involvement of the Takayasu, there are 5 types of Takayasu, and this is the type that our patient had, is type 4, that actually is affecting the abdominal aorta and bilateral renal arteries. Based on our publication with case series, and we looked at the literature review, only 5% of cases in Takayasu with Takayasu in the United States had type 4. It's a pretty rare disease. The most common type is type 5, and then type 1. But as I said, type 4 is pretty rare. How often do you see thrombosis with Takayasu Arteritis? We kind of searched literature, and we found really actually Takayasu by itself is a risk factor for thrombosis because there is really activated platelets and also coagulation activity. The factors are pretty active. We have not seen any case that presented with iliac artery thrombosis with Takayasu, given the rarity of type 4, and that was actually our case that we published was the only case. So how do we manage Takayasu? Again, we start prednisone, slow taper. There's some data for DMARDs, but actually there's some data for tocilizumab, again, based on a low control randomized trial with very low number. There was some trends toward improvement. We are waiting for another trial that's currently ongoing. Anti-TNF agents actually here work, contrast to GCA. So I usually call and speak with rheumatologist colleagues and try to get them on anti-TNF. Revascularization based on paper, patency in 9.4 years, around 10 years. For open, it's 79%, for endo, 52%. And again, all comes down if the patient is having inactive disease. Based on the paper that come from Tom Bauer and Dr. Sullivan, actually, when he was at Mayo, that looked at patients with Takayasu that presented and needed intervention. Only 42 patients out of 251 patients with Takayasu at Mayo that actually required surgery. The patients that were operated on actually had really no significant complications, no mortality, MI, or stroke. However, patients that had active disease based on steroid use had more need for revision, or patients that had, again, if you look at the activity of the disease, patients that had active disease had to be reintervened more often. Prognosis, 5-year survival is about 80 to 90%. Giant cell arteritis is almost kind of normal survival, but Takayasu people, because this disease starts early, you actually see more mortality and morbidity in terms of the disease activity. And long-term prognosis, the patients also that require surgery, from a paper from Japan, survival in hospital post-discharge about 90%. Overall survival in 20 years, it's not that bad still, 73.5%. And about 14% of these patients came down with aneurysms that developed at the anastomotic location. All right, so we talked about GCA, right? We talked about Takayasu. Let's kind of catch up on the third case, which is kind of more complicated and probably more rare than the other cases. A 51-year-old gentleman, this time is a male, so males are not immune, I guess, presented with 2 weeks history of fever, night sweats, and chest pain, and of course also has a friction rub, erythematous rash on all 4 extremities. Labs showed leukocytosis, anemia, significant elevation of ESR and CRP, though troponin is normal. There's cardiomegaly on the chest X-ray, flatter on the EKG, and ejection fraction is 30%. What the heck is going on? And the patient has, moderate pericardial effusion, and this is the CT angiogram. And again, this is an axial view CT angiogram of the chest. You see there is a significant wall thickening, not only significant wall thickening of the ascending aorta, but look at the diameter. If you measure, it's about 6.5 centimeter. And if you look at if you go distal a little bit, you see that the aortic arch is also involved, significant wall thickening of the aortic arch. I can tell it's about 8 millimeter. And this is the abdominal, actually the descending, which I didn't show here. The descending thoracic aorta is paired, but you see significant wall thickening of the abdominal aorta as well, too. So for the workup, ANA was positive, which can be positive in most of autoimmune diseases, but C-ANCA was significantly positive, and especially the proteinase 3 type that we see really strongly with ANCA vasculitis. Rheumatoid factor was positive, not very specific again. The rest of rheumatological workup was negative, including IgG4 level. Also, the chest CT, which I didn't, there was a different view that showed actually significant lymph node involvement as well. And the PET scan showed increased uptake around the ascending and abdominal aorta, proving that there is an active disease that's going on. Blood cultures were negative. Skin biopsy showed perivascular neutrophilic infiltrate that was non-specific, unfortunately, like most of our biopsies that we send non-specific infiltrates. And differential diagnosis. So the patient had lymph nodes, significant lymph nodes in the chest, rash, so that's kind of sign of a small vessel vasculitis, right? And the patient is kind of younger as well too, and there is a systemic involvement as well too. So that and the ANCA was significantly positive. That's why we thought about, is this an ANCA-related vasculitis, or it's rheumatoid arthritis-related aortitis? Management, the patient unfortunately failed, steroids. We gave him steroids. First he had some improvement, but then after that, we couldn't reduce the, couldn't taper down the prednisone, tried methotrexate, tried tocilizumab with no help. And then finally, when we said, well, this most likely looks like an ANCA vasculitis, and we gave him rituximab, and he actually improved significantly because patients actually with C-ANCA vasculitis respond very well to rituximab most of the time. And we were able to come down on the prednisone to 20 milligram. Final diagnosis that we're thinking that the patient has is C-ANCA-related aortitis or vasculitis. This is his CT angiogram when he saw me about a month ago. Significant improvement in the wall thickening, and now the aortic root in the ascending aorta is no more than 5.6 centimeters. And this is his abdominal aorta, significant improvement. His labs are normalized, and he's following with the thoracic surgeons, cardiac surgeons right now. So what do we know about ANCA vasculitis? There are two major types of ANCA vasculitis, the C-ANCA or cytoplasmic ANCA or perinuclear ANCA. If this is positive and this is positive, you think about granulomatosis with cholangitis. In the past, we used to call it Wagner disease, remember? Now the name has changed. P-ANCA, if the patient has P-ANCA vasculitis with MPO type positive, we think about microscopic cholangitis, eosinophilic granulomatosis with cholangitis, which is used to be Church-Strauss disease. And sometimes we see renal limited vasculitis with this type as well too. These are the criteria I just want to pass in the interest of the time. The treatment is usually glucocorticoid combined with cyclophosphamide or rituximab. There's more really good data to support the use of rituximab at this point if you need really a fast response. So the second case is actually taken from a colleague of mine, Dr. Stone from Harvard, who has a lot of interest in this disease, which I'm not going to disclose yet. 7-year-old gentleman, history of hypertension, diabetes, presents with left neck mass and right eye swelling, significant weight loss, and abdominal pain. Again, everybody has abdominal pain and night sweats and constitutional symptoms. But this is different because the patient has an eyelid swelling and left submandibular mass that's tender when you examine the patient. Patient has leukocytosis, anemia, significant LFTs elevation, and lipase amylase are really, lipase and amylase, which is not written here, is also kind of elevated. So the patient has signs of maybe it's some liver involvement and pancreatic involvement as well too. Chest X-ray also showed revealed mediastinal lymphadenopathy as well. And the CT actually, I'm just going to show you the CT. Again, this is an axial view CT angiogram of abdomen pelvis. Again, you see significant wall thickening of the aorta. Which is which? Is this giant cellulitis again? Is this Takayasu? What the heck is going on? So if you look at the coronal view, again, you appreciate significant wall thickening of the aorta, and that goes down all the way down to involve the bilateral common iliac system as well. So the biopsy that was taken from the submandibular gland, right, it actually showed lymphoplasmocytic infiltrate, which is kind of a pathognomonic thing for this disease, obliterative phlebitis and steroidiform fibrosis. And this patient actually had an IgG4 related disease, which has actually started, again, a lot of interest out there in the literature. What is it, that IgG4 related disease? It's an immune-mediated condition with multiple disorders that affects multiple organs that share the same features. So usually these patients will have tumor-like swelling of the involved organs, and we're going to go over these, what kind of organs. They actually have lymphoplasmocytic infiltrate. If you stain these cells, they are positive for IgG4 antibodies. And they have actually pathological findings of storiform paternal fibrosis. And if you measure IgG4, not always, it's not 100% you're going to see IgG4 elevation, only in 60 to 70%, most of the cases, but not all of the cases. Because some of my colleagues used to say, okay, so IgG4 is negative. This is not an IgG4 disease. You have to look in the tissue. So major presentation, it can affect the salivary glands, like our patient's submandibular involvement, lacrimal glands, and they actually come with retroperitoneal fibrosis, including periaortitis, pancreatitis, and cholangitis. And sometimes the thyroid can be involved as well, too. Diagnosis, clinical serology, as well as radiology. They're looking at the, organ involvement and pathology. Like, you can check to see if the tissue is staining positive for IgG4. And the treatment is prednisone, as well as rituximab, that can be used to spare the patient the side effects of prednisone. All right, IgG4, again, presented with the same similar presentation, abdominal pain, aortic wall thickness. Case 5, okay, so this is the courtesy of another colleague of mine from Italy that he spends a lot of time actually taking care of patients with this disease, which you're going to know in a second here. 55-year-old male presented with hypertension, with history of hypertension, present again with abdominal pain. But this time, the difference is the patient has left flank pain that goes to the left groin area. In a physical exam, significant tenderness in the left flank. Labs are important for not only SR and CRP elevation like all other patients, but the creatinine is really elevated, 3.2. Abdominal ultrasound showed hydronephrosis in the left flank. That gives you a little key there. And the rest of autoimmune workup, infectious workup is actually negative. So this is the biopsy that they take with the CT-guided needle biopsy that showed significant fibrosis and significant inflammatory cell infiltrates of the abdominal aorta. And that's why we call this, they made the diagnosis of periaortitis or retroperitoneal fibrosis, the old name. Now they call it more of periaortitis. It's a very rare condition, actually, that, you have to prove that there is inflammation, but also fibrosis. Most commonly affect one of the ureters because the fibrosis and the inflammation can occur in case, actually, the ureter and leads to hydronephrosis like our patient has. It can be secondary to many things. IgG4 can lead to this, and other diseases listed here can lead to periaortitis. Diagnosis is labs plus the biopsy showing fibrous tissue with inflammation. And treatment can use prednisone again, methotrexate, tocilizumab, also data for rituximab as well too. We still have 3 cases. I know the cases are all similar, right? And then I'm going to give you some kind of keys to kind of try to figure out which is which, right? Case 6, 51-year-old female presents with chronically. This is also a case from other colleague of mine. Chronic leg pain, periumbilical abdominal pain. Labs, CBC is kind of normal, but again, ESR and CRP elevation. X-ray actually showed osteosclerosis of the epiphysis of the bones, long bones in the legs. And the CT angiogram, again, this is an axial view, a CT angiogram of the abdomen and pelvis, showing again significant wall thickening of the aorta. But what is this here? It looks like there are some hair growing for the capsule of the kidneys, both sides. Look at this. And if you look at the axial view, it's kind of weird. What is this that's going on up here? So this patient had Erdheim-Chester Disease. And it's a multisystem, actually, disease that there is an infiltrate of non-Langerhans histiocytosis. There's a lot of histiocytes that actually affects most of the tissues, including the abdominal aorta and retroperitoneal space, and that actually can look exactly like IgG4, Takayasu, GCA. BRAF V6E, which is a gene mutation, and it can be seen in 50% of the cases. So the workup that you do is you try to take a biopsy to prove that there's a non-Langerhans histiocytosis. You check for the mutation, and some of these cases had elevated ESR and CRP. And we call that the thing that you looked at the kidneys looks like hair growth. We call it hairy kidney and coated aorta because the aorta looks like it's coated. Oops. And so the management based on the if the mutation is positive or negative. But I just want to show here that periaortitis is seen in about 60 to 66% of these cases. Last 2 cases, quick here. Case 7 here, it's a 59-year-old man. That's actually a patient of mine, history of hypertension. and presents with abdominal pain. There's significant tenderness in the abdomen. Again, ESR and CRP, they are elevated. And then extensive workup actually was negative. And if you look at the CT angiogram, again, significant wall thickening of the aorta here. And because we did not find anything positive in this gentleman, and he improved significantly with prednisone and methotrexate, and actually we kind of call him idiopathic inflammatory aortitis because nothing else was positive in this patient. And usually these patients respond really well to steroids and methotrexate, and sometimes there are some cases for tocilizumab that these patients respond to. And this is his CT angiogram. Lately, I was able to take him off steroids, and he's doing great right now. And this is his abdominal aorta later on. This is the sad case that we had recently in our center, 79-year-old man, history of rheumatoid arthritis. This is to kind of add to the complexity of making the diagnosis in these patients. He had a history of rheumatoid arthritis, diabetes, hypertension, hyperlipidemia, presented with abdominal pain and back pain. He had actually those abdominal pain for a while, but it got worse recently. He's already on infliximab and methotrexate for rheumatoid arthritis, but he's been off steroids. He was supposed to be on steroids, but he stopped steroids previously and came with abdominal pain. And his labs actually, you see leukocytosis, ESR and CRP elevation. Blood cultures were negative because you think about infection in this patient who was immunosuppressed for a while. And to the point that we went down and did an MRI of the back to make sure there's no osteomyelitis of the back, and that came back negative. The only thing that came back positive, that was questioned even, that his urine culture came back positive for MSSA. So recommendation by ID, he was given ceftriaxone symptom on Caflex. So what we did, I got actually involved in the hospital. I said, so since everything is negative, there's no really, maybe it's not infectious, so let's kind of put him back on the steroids that he was supposed to be on and bring him back in a month. So, and we did actually, this is his CT when he first presented. And you see also, there's kind of atherosclerotic plaques here, and there's some kind of wall thickening. It looks like maybe erythropoietin, fibrosis or periaortitis. And then, he came and followed me in a month later, and actually his symptoms improved significantly. Yet his ESR and CRP were still elevated, and he told me that he stopped his prednisone 5 days prior because he ran out of the prescription. And the blood cultures, I look back, they are still negative from the hospital admission. And CT, I'll show you the CT actually here. So the plan, I'll show you the CT in the next slide. But the plan for him is to continue on the taper of prednisone, and statins and control his blood pressure. And my plan was to bring him back in 2 to 4 weeks. So this is his CT angiogram. Actually, I remember sharing this with Dr. John Lesser. It's more kind of a periaortitis. Now, it's more kind of, there's an ulcerated plaque. It's kind of maybe reduced of that stuff, but now it's kind of, there's an ulcerated plaque. I said, we'll just continue with what we're doing. Unfortunately, this patient, with a surprise, came back 4 days later with this CT angiogram. And the patient actually, unfortunately, was taken to surgery, and his culture from the periaortic tissue was positive for MSSA, where it was in the urine, and unfortunately, the patient did not make it. So this can be very serious, and making a right diagnosis is crucially important. All right, so infectious aortitis is very rare, right? You don't think yourself the only staff in the hospital. There's other staff in the hospital. But so the patient, how do we differentiate really between infectious versus inflammatory aortitis? Usually patients with infectious aortitis, they have leukocytosis with left shift. Procalcitonin might help us, can be elevated. History of recent infection, positive blood cultures, not always, 50, which makes our making diagnosis is pretty hard, 50 to 75%. Worsening symptoms and immunosuppression. Our patient actually symptoms improved though, which is kind of interesting. Usually there is a symmetric aortic wall involvement. Like our patient wasn't like whole, circumferential, was a little bit on the one side. And usually patients with, if you take them to for PET scan, they have very high SUV. So this is our case studies. I'm going to finish. I'm almost done. So what kind of experience that we have with this disease? This is our case series between 2009 and 2015. By the way, we diagnosed another 15 cases of aortitis after that. So we have quite a good experience. 30 cases of aortitis in one practice. That's quite a few because, as I said, it's very rare. So we screened 171 patients with history of GCE, Takayasu Aortitis, or other autoimmune disease. The patients that had involvement of the aorta were only 15 cases. Takayasu were 8 cases of Takayasu, which is kind of a good number for our institution. Idiopathic 5 and genital arteritis of 2. Just going to skip, the methods here. And the results, age, usually as I said, Takayasu patients are younger than patients with genital arteritis, idiopathic inflammatory aortitis, usually in the middle. And they are actually, most of these patients are females, except for idiopathic inflammatory aortitis. They're more males than females. Again, the number is low, but if you search the literature, it's kind of concur with our data. And there is really smoking history is prevalent in patients with idiopathic inflammatory aortitis. Most of the involvement in the thoracic, but actually if you look at the idiopathic inflammatory aortitis, usually affects the abdomen. All of these patients receive steroids, which is kind of the main initial treatment. Some of these patients had to go for surgical intervention. 4 of the Takayasu cases, because the Takayasu patients will present with stenotic lesions or occlusions, and that may require intervention. And 1 patient with genital arteritis. And they actually, the surgical or interventional outcome was successful in all the cases. There were some minor complications. Remember that Takayasu young lady that she had she had actually a right iliac artery dissection as a complication because she had to be operated on because of her critical limb ischemia. So the conclusion, in our series, we had more Takayasu cases. And again, this is involving the aorta only. 4 of these cases had 4 of 5 cases with idiopathic type had smoking history. Most of the patients actually presented with Takayasu presented with stenosis. All idiopathic cases had abdominal involvement. And then most of these patients really did well with medical and surgical intervention. How do we work these patients? As probably the message is pretty clear. These patients are really seriously sick, and you have to make the right diagnosis because treatment can be different, as you could tell. So what we do actually kind of baseline workup, including a CBC, SRS therapy, and all this kind of autoimmune workup. Of course, imaging is very, very important. What makes us different from rheumatology practices, rheumatology just go by the looking at the patient, looking at the labs. But here we can look at the patient, we can look at the labs, look at the images. We have quite a good experience here with the help of Dr. Lesser. He's taught me a lot about CT too. And histology too. I think it's very important. When you can't take a tissue, it's important. Like we used to say, a tissue is an issue, is the issue. And either the patient is going to end up having infectious aortitis, which is pretty rare but significant. You have to get ID involved. If you have any doubt about the patient having infectious aortitis or infectious etiology, you have to consult ID. For inflammatory aortitis, try to get us involved. I have a lot of interest in inflammatory aortitis along with my colleagues here. You can call us and we'll be happy to figure things out. And then based on the diagnosis, we try to kind of make the treatment. This is something that I hate to do with my kids, and I still do, because trying to make, what's the difference between the 2 images, and this is kind of similar to what you need to do when you look at the CT. These are the CT angiograms of the cases that I went over today. Most of these cases have similar findings, right? You have aortic wall thickening, and you just have to figure it out. Differential diagnosis, I'll give you some keys here to make the diagnosis. Think about GCA in a female patient who are 50 years or older with headache, elevated markers, PMR, and positive temporal artery biopsy. Think about Takayasu in a female patient who's 40 years or younger, 40 years of age, with blood pressure differences, poor pulses, and imaging findings. IgG4, remember the classic organ involvement, elevated IgG4, especially on the tissue with some fibrosis and lymphoplasmacytic infiltrates. Periaortitis, think about that in patients with hydronephrosis and patients with biopsy positive for fibrosis and inflammation. Erdheim-Chester Disease, think about bone involvement and non-Langerhans histiocytosis involvement. And again, despite the fact that you can do all kind of the workup that you think of, there are some cases that we don't know the underlying etiology. We call those idiopathic inflammatory aortitis. I think you all know this figure, right? So if you remember when we went to Iraq to look for the mass destruction weapons, right? So everybody was thinking, well, we're going to find the weapons. But when we didn't find the weapons there, and Mr. Rumsfeld was asked, this is what he said. There are known unknowns. There are things that we know that we know. There are known unknowns. That's to say that there are things that we know that we don't know. But there are also unknown unknowns. There are things that we don't know. This is literally what he said. So we didn't change anything. This is exactly what he said. So what I'm trying to say is also there are a lot of unknowns about aortitis. So conclusion, aortitis, it's a very rare disease, can be inflammatory, infectious, neoplastic, idiopathic. More research is needed to classify these disorders. Actually, some of these leaders, thought leaders out there, they believe that they are all the same disease, but actually with wide spectrum, because they're all kind of similar. Differential diagnosis can be very difficult, as I tried to point out through my presentation. It requires extensive workup and involves really a multidisciplinary approach. See somebody that's involved here, I'm kind of involved in this. Determining disease activity is very challenging, if the disease is active or not, before you take the patient for a procedure. And management includes steroids and steroid-sparing agents. Revascularization only when the patient has an active disease and if you have significant or need for intervention. I think I'll stop here. I think I have 10 minutes and see if there are questions. Thank you. That's John.
Fantastic.
Yeah, thank you.
When you think of the frequency of atherosclerosis in our patient population, what about the patients who present with abdominal pain and an atherosclerotic inflammatory aneurysm? Do they have elevated markers, and how do you differentiate it?
Okay, this is a very good question. We actually had taken care of patients with atherosclerotic aneurysms. Some of them, they have a slight, especially if they come with a recently ulcerated plaque, you see CRP elevation. As a matter of fact, CRP is a surrogate of bad outcome in these patients, as you know. So we have seen, but not to the point that the CRP will be significantly elevated. ESR usually normal, unless the patient comes with this significant dissection of that ulcerated plaque along with the ulcerated plaque. But usually CRP, especially the high sensitivity CRP, is elevated, not just the regular CRP. We still do, if there's a significant wall thickening along with that atherosclerotic plaque, we do tend to do the workup, at least to rule out infectious process as well too, right? So yes, we do see these patients, and we do the workup, especially if there's a significant wall thickening along with that. Yes, yes.
Great presentation, Nedaa. I have a question regarding the ascending and arch aneurysms. So first, are there any guidelines in terms of the sizing other than the ACC/AHA that we know for the inflammatory aortitis versus the degenerative aneurysms? Yeah. And the second question is, if once it's resected and studied, are the findings similar? I mean, obviously there's inflammation there.
Yeah.
Is there also like elastin fiber fragmentation and the other?
Yeah, I see like other
findings similar.
Yeah. So this is a very good question. So what is the threshold for operating on these patients? Actually, the problem with inflammatory aneurysms for ascending and descending as well as abdominal, they actually can get worse very quickly. So you're absolutely right, they behave different than atherosclerotic aneurysms or degenerative aneurysms. And so we really keep eye on these patients, and instead of bringing them back in 3 months or 6 months, we tend to bring them very, like our patient that presented with ascending aortic aneurysm. And if you actually give them the right treatment, make the right diagnosis and give them right treatment, they tend actually to do better. This gentleman that I presented with, C-ANCA vasculitis involving the aorta, when he started it was 6.5 for the, it literally needs to go for surgery. But then, of course, because he's active disease, we start to kind of bring the disease into inactivity, and then actually his aortic would actually get better. But if they are not on the right treatment, you're absolutely right. Sometimes they have to bring those patients sooner to make sure that this doesn't get more degenerated. In terms of the biopsy, the most kind of the pathognomonic, not pathognomonic, but the most common findings on the pathology, you see actually inflammatory cells that's there. And if there's a chronic disease there, you see fibrosis that actually started to take place of that, especially in Takayasu Management. There was a patient that had to go for aortic reconstruction surgery, and all his aorta was actually fibrotic. He was 30 years of age. So yeah, more than degenerative, we see more sclerosis and fibrosis. Yeah, sure.
Nedaa, with respect to Takayasu Aortitis, because it afflicts younger population, what do we know, if anything, about the use of the new anti-interleukin drugs and et cetera in that particular case, as opposed to steroids, which we used to use?
Yes. So there's good case studies for tocilizumab, which is an interleukin-6 inhibitor, that actually showed significant improvement. Tocilizumab, which is Actemra, it's a drug that is originally approved to be used in patients with rheumatoid arthritis and other rheumatological disorder. It was studied in GCA, and it works really well. It's the only FDA approved drug for GCA for genital arteritis. And there's some data. There's actually a control randomized trial with very low number that showed trends towards improvement with tocilizumab, which is an interleukin-6 inhibitor. And so there is actually emerging data because, as I said when I was presenting, steroids can be devastating for patients. There are a lot of side effects, and it's just, destruction. And so, yes, we tend to use more of these interleukin or other, newer agents in these patients. Yeah.
Yeah. The infectious aortitis, if you confirm the diagnosis with some form of cultures, do you always have to operate at some point? Or?
Okay, so this is a very good question. So we tend to kind of, talk to my colleagues from vascular surgery. Of course, you have to have the disease under, control. Sometimes, these patients can be sick, and operating on them might be even higher risk than just to watch and see. We had infectious aortitis that we sent for operation with my colleagues, and there are some cases that we had to give antibiotics in some of these patients. Once you get really infected, it's very hard to get rid of. Some of these patients, we get stabilized and then send them for surgery, and some of them, they had to go for surgery because there was no other options. But they are very high risk, either way. Great. Well, thank you so much.
Thank you. And on your way out, please say thank you to our sponsors. Outside, we have Barb Jones and Lindbergh with Novartis, and Jillian Hendrickson and Laura Elms with Pfizer.
Yeah.
Thank you.